Hello, everyone. This is a session of Asian Secret Sauce. I'm a chair of this session. I'm Changano from Korea. So we don't have time to explain everything. So Achima will co-chair of this session. So I'll introduce first speaker, Kentaro Oku from Japan. He will speak about universal skin regeneration. Yes. Thank you, Oku.
Thank you. Thank you for inviting me as a speaker of prestigious congress, especially run by Dr. O. I'm Dr. Kentaro Oku from Japan, and my session title is Universal Skin Regeneration, a colorblind protocol designed for Asian skin. This is my short introduction. Actually, I am a scientific reviewer of Journal of Cosmetic Dermatology and Lasers in Surgery, Medicine, and so on. The reason why I served as a scientific reviewer is seeing the thing from a new perspective is very important, I believe. Because if we see one thing in a one perspective, the solution will not be find out. But we need to find out the another countermeasures to solve the problem as much as we can. So, in our APAC region, the skin regeneration, including pigment removal, of course, this is the most desired treatment, I believe. The problem is our skin type. When we want to use higher energy or wider coverage of area and depth with one treatment session, our skin would fight back against us, such as PIH, PIE, long procedural downtime, and the melanocyte hyperactivity leading to the worsening of the symptoms. So, before we use energy-based devices to improve the skin itself, meaning to remove the pigment, to tighten the skin, and to get facelift, I think we need to modify the skin reaction with color-blind techniques. To think right strategy to modify the skin reaction, let me revisit the interaction inside the skin in cellular level. In a world of skin, the main characters are keratinocyte, melanocyte, fibroblast as cellular component, and the extracellular matrix such as collagen, elastin, and myosin. They are connected with cytokine systems like this figure. Of course, this figure is so simplified version, as you can see. It's not everything. But the point is this one. If we want to reduce the activity of melanocyte to prevent PIH, we could approach it from many directions. On the other hand, we have to use external stimuli as an enhancer to activate the skin system. So we need to sedate melanocyte in more effective, powerful way. In a use of laser, your target is chrome-4, melanin, hemoglobin. These laser energy need to penetrate from the surface to dermis. It means you need to sacrifice the melanocyte. You need to add some energy as an external stimuli to the melanocyte. That is why we need to protect them before using any kinds of energy-based devices. Thinking the direct approach to the melanocyte, such as using oral antioxidatives, topical whitening agent, and intradermal injection through tranexamic acid, they have some efficacy, we know, but Also, we know they are not enough to sedate activity of melanocyte. In the interaction of skin system, where is the most effective target to reduce the activity of melanocyte? I believe the most possible one is fibroblast. As you know, the fibroblast is the center of the interaction of skin itself and influence to all the key players, key components in the system. When we can successfully activate the fibroblast, the regulatory effect to melanocyte would be maximized. Okay, fibroblast is the target before using energy-based devices. Next task is how to activate that. As you know, the fibroblast has two main activating systems. The first one is mechanical stretch. If we lose the tension to the fibroblast will be deactivated, as you know. In the originate state of the fibroblast, they are tensioned like a spindle shape. If you see the round-shaped fibroblast, this is a proof they are deactivated. So we need to stretch out to the spindle type. And next one is applying optimal heat. As you know, heat is a very important component to activate the cell itself. But if you apply too much energy to the fibroblast or any other kinds of cells, the cell will be destroyed. It's not good. Each cell has an optimal heat energy, optimal temperature environment. Especially in the fibroblast, 42 degrees or 43 degrees Celsius would be optimal. So, adding appropriate tension to the fibroblast and adding the optimal heat to enhance the activity would be the very good way to activate the fibroblast itself. I named it crosstalk protocol to achieve these two conditions. I will show you. This is the outline of crosstalk protocol. I will use parallel beam ultrasound to add the optimal heat to the dermal, especially the papillary dermis fibroblast, and cross-linked hyaluronic acid injection, intradermal injection, to apply the tension, appropriate tension to the fibroblast. I have actually a specific technique to utilize a parallel beam ultrasound to maximize the heat energy in one pass technique. I named it thermostrate technique with 3.0 to 3.4 joule per shot. Maybe you know the system. This system can emit the 3.0 to 5.0 joule per shot. Actually, I use the lowest energy to apply the heat. Because we have a simulation data, this 3.4 or 3.2 joule got a very good temperature in the papillary dermis. I'm not talking about the reticular dermis. I'm talking about reticular dermis where the fibroblasts are located. Of course, the majority of fibroblasts are located in the papillary dermis. That is why we need to focus in on the temperature in the papillary dermis. Using 3.4 joule with one shot thermostrate technique like this, we can add the thermal energy in sufficient way and its safest way to achieve the optimal heat condition with vectorized facial skin tightening at the same time. I mean, vectorized is from lower to upper. Skin tightening like this is a very good result for facial skin tightening. And on the other hand, we can apply the optimal heat to this area. And of course, I will use the cross-link hyaluronic acid injection, intradermal injection, 1 cc per cheek. 1 cc would be more or less, I think, but the 1 cc per cheek is enough to apply the enough tension to activate the fibroblast. This is a data of FaceQ. It is a satisfaction data of from the patient. The satisfaction rate of the skin itself. If the patient feels the skin is good, the rating would be 100. If the patient got the long sensation of the skin, the rating would be 0. The 0 is the lowest, the 100 is the highest. But before the treatment, we see the average would be 35 of the FaceQ score. But after the crosstalk protocol, 4 weeks, and then after 8 weeks, we can see the increasingly upping the FaceQ score from 35 to from 55 without no intervention rather than crosstalk protocol. This is a clinical result of crosstalk protocol. Left one is the before, and the right one is the after one session of the crosstalk protocol. Yes, you're right. Skin tightening and skin evenly toned and touching the face. Very gentle one, but very obvious effect was seen. And this one is the same. Before the session, she got some enlarged pores, erythema, and the rough skin. But after that, we can see the very clear result without causing downtime, including PIH, PIE, and longer downtime. The only downtime is a 30 minutes erythema. That is why I prefer to use this crosstalk protocol to regenerate the skin. But of course, our primary target is the pigmentations on our face. So, my treatment strategy would be prime the skin crosstalk first, and then target the pigment precisely. So, this is the before. And day 1, I applied the crosstalk protocol, universal, color-blind, skin regeneration protocol before the laser. And I will wait 60 days because you know the dermal regeneration process takes time. And in a day 60, I will apply the picosecond Alexander light laser to destroy the target, precisely melanoma only. And after that, we can see the almost clear result without causing PIH, PIE, and no longer downtime. And this one, of course, you can see the melasma. The treatment protocol is the same. Prime the skin first with crosstalk protocol and destroy the target precisely. And after one treatment session in day 90, we got almost clear result like this. And the 50s. Seborrheic keratosis is very difficult to destroy it with picosecond laser, but if you prepare the skin in the right method, you can decrease the pigment like this. And in her 60s patient, if we can apply the optimal heat energy and optimal tension to the fibroblast, your patient's skin reaction would be maximized like this. This is the one session of treatment. Only one session is needed if you can prepare the skin well. This is the outline of crosstalk protocol. So it's a color-blind fibroblast reactivation strategy, effective and safe and standalone treatment. of course, as a skin primer. Thank you for your kind attention.
Sorry. Thank you, Dr. Oku. So in this session, we have 10 speakers. Please keep the time. Next speaker is Professor Vasanov Bachiremon. He talked about managing melasma-prone skin. Please.
He's a pigment expert, melasma expert, from Mahidol University in Bangkok, Thailand.
Okay.
And,
Thank you for the introduction.
Yeah. So everything about pigment.
Ask me everything
Okay.
about pigment. Okay, so this is the session about Asian secret sauce. So I think I'm gonna share with you about how to management of melasma-prone skin. You know that we have many patients with melasma, but what I want to talk more is about the patient who are going to develop melasma, since that we have so many patients who are prone to develop melasma. So how to take care of this group of patients? So we know that this is melasma, right? You can visibly, very clearly see that this is melasma patch. But before this patient develop melasma, sometimes they have like the excess melanin that accumulate under the skin in the basal cells that you don't visibly see the dark patch yet. But we know that these people in the future, they're gonna develop melasma. So let's see what we can do for them. But before we go to that, I think we have to understand the pathogenesis of melasma, that this is the multifactorials. And you can see the first one, the green arrow, genetic factors that we are talking more nowadays, because we know that there are many genetic issues that we discover nowadays about the melasma, about the development of melasma. So if you look through this study, we found that we have many candidate genes that prone the patient to develop melasma. And then that's why we are not so surprised if our patient who has melasma, you go back and ask your patient, hey, do you have anyone in your family has melasma? And then your patient will say yes. And we think that it should be inherited in the autosomal dominant but variable expression. By the way, we still want more data about this, but we know that at least they have genetic propensity. And then we know that this group of patients, you have to instruct them not to take like hormone or especially estrogen, else they're gonna develop melasma in the future. And there are so many hormones that we have to pay attention, but most of the time we know about estrogen because there are so many data about estrogen, right? But thyroid hormone, luteinizing hormone, and also ACTH, we have few limited data about this, but still there are some evidence about the thyroid dysfunction as well. And then when we talk more about estrogen, why estrogen is important about development of melasma? Because we found estrogen receptor in the melanocyte, and not only melanocyte nucleus, but also the cytoplasm of the melanocyte as well. But it is more concentrated in the nucleus of melanocyte, which means that if you have high level of estrogen, it can incorporate and react with the estrogen receptor at the nucleus of melanocyte, and then your melanocyte will be more active. And this data show that when you incubate estrogen with melanocyte, you see more melanocyte proliferation. And this is the standing, you can see estrogen receptor beta positive in the lesion, in the blood vessels of the melanocyte, of the melasma lesion, and when compared to the normal skin. And this is very interesting because when we have the patient who develop melasma, when they currently taking oral contraceptive pills, you just instruct them to stop the oral pills and then you change the contraceptive methods. This study show that when you ask them to stop and then they change the contraceptive method without estrogen, and then melasma seems getting better, but you have to wait. Some patients you have to wait until 2 years. Some patients 1.5 years, some patients 7 months, but you have to instruct your patient to change the contraceptive method. And this is a patient that after they switch to the intrauterine device without estrogen, 5 months, you see improvement of melasma without any treatment, without any lightening agent, just change the contraceptive methods. And then when we look at another aggravating factor that we have to instruct the patients to avoid is the heat. There are more and more data nowadays about the heat that can aggravate melasma worsen, not only UV. And this is something that you might want to instruct your patient who has melasma or who has propensity to develop melasma, that they should avoid heat source, hot yoga, sauna, steam room, cooking, and always keep the skin cool, like cold mist, thermal water spray. And the thing is that the sunscreen that incorporate the mineral sunscreen that can reduce the heat absorption in the skin as well. So you have to make sure that the sunscreen regimen that you recommend to your patient have mineral sunscreen component. And when we look at this, the monopolar RF, that's the thing that we do a lot nowadays to do the lifting and tightening. But you look at this, if you go with the longer time of treatment, thermal temperature is increased, and it can increase up to 60 or 70 degrees Celsius underneath the skin. So that means you are prone to develop melasma. So when I have this group of patients come into my office and ask me for tightening or lifting, I am a bit worried about doing aggressive parameter for the monopolar RF. But you still can do, but you have to be aware of the adjust your setting. Focused ultrasound seems to be more okay in this group of patients because the heat is concentrated, just only the specific layer. But I would like to say that not all ultrasound device, not all focused ultrasound device can do this job. Some of the focused ultrasound device in the market, when you continuously do, the surface temperature also increase. For example, the orange one, the surface temperature can reach up to 50 degrees Celsius, and that means you can create melasma worsen as well. So you have to be aware, even though it is safer compared to RF, but still have to be aware. The one that deliver with the specific heat, and you don't see the heat diffuse to the upper part of the skin, is the one with the visualization system. Another thing that you might want to think of is the visible light and infrared light that you have to instruct your patients to avoid, because this can make the melasma worsen as well. And if you look at this, when melanogenesis, not only because of UVB, but also UVA and visible light, this is observed. This observation, this study show that both, all three sources, UVB, UVA, and visible light, can make the melanogenesis and make the melasma worsen in both melasma and also the surrounding skin that don't have melasma yet, but in the future they're going to have melasma. So you have to instruct your patient to avoid UVB, UVA, and visible light. And UVB, UVA is very easy, but the visible light is a bit difficult because you know that not so many sunscreen can do that. Especially if you want to protect, you can go with tinted sunscreen with iron oxide, or you might want to think of sunscreen with antioxidant, because some formulation they don't want to incorporate the iron pigment because of unpleasant texture and color, so they incorporate antioxidant. But still, you have to think of the sunscreen with antioxidant or iron oxide that you want to protect. And this is to show you that when the patient treat melasma and already subsided, the melasma can recur. So you have to make sure that the sunscreen is okay. So this shows that if you have only UV filter when compared to UV and visible light protection, visible light filter, you can see the recurrence of melasma can recur if you go with just UV filter alone, which represent on your right side. But on your left side, if you have visible light protection, the severity score is not going back to the normal yet, just recurrent a little bit when compared to the one without visible light filter. And also UV, we know that we have to protect the skin from UV. And we can go with sunscreen with many ingredients, right? And physical methods. And also nowadays, we are talking a bit more about injectables. And this is my study that recently published that I used intradermal neurotoxin for protection as a role of UVB protection, because this found that you see this study. The upper one is the skin that treated with normal saline, and then the right side, the upper right, you already ate with UVB, and then 7 days after UVB, you can see skin become dark, right? But the skin that pre-treated with intradermal toxin, and then you already ate with UVB, you don't see much tanning. So we think that there might be some protective effect from intradermal toxin against UVB-induced hyperpigmentation. And you are not so surprised because this is the basic science study show that with the presence of neurotoxin, you can reduce melanogenic cytokines that release when your skin exposed to UVB. So majority is basic fibroblast growth factor, interleukin-1 alpha, and prostaglandin E2 level is changing with the presence of neurotoxin in the dermis. So you have to inject very superficial. And this study, this picture show that on both sides of the face treated with the triple combination, but the right cheek, you do additional neurotoxin injection intradermally, and then you can see 2 weeks, the right cheek show a better result when compared to the left cheek that you just apply the triple combination cream alone. So we did a larger scale study, just show you this one. We inject neurotoxin on day 1 and 12 week, but we let the patient apply the triple combination cream from the first day until the 12 weeks, right? And then after 12 weeks, we stop the triple combination cream. And then we do the split phase study, means that one side just treat with the cream alone for 3 months and then stop. So you expect the melasma will be recur. But on the other side of the face, you do neurotoxin injection for first session and also the 3rd month, and the cream apply only 3 months. And then you can see that if you look at the gray is apply the cream. Then after 12 weeks, melasma recur. But the orange, when you do the injection at the 3rd month as well, you can see melasma not recur. But there are some period, the summer period, that you see melasma worsen a bit, but this is forgivable. And the patients are more satisfied with the side that treated with intradermal neurotoxin. So you have to think of the neurotoxin that against UVB-induced hyperpigmentation and also can be your good friend to make your melasma treatment better. Not only enhance the treatment effect, but also prevent of melasma recurrence. So you can go back and read that study that we already published. And when you know that we talk a lot nowadays about the dermal issue, dermal change in melasma, because it's not just epidermal disease only. It's now, we have to focus more on the dermis. And we know that there are many mast cell chronic inflammation in the dermis. We have collagen change, solar elastosis, neovascularization. So this is the update, actually not update because 5 years or 4 years already that we published about this in terms of dermal changes in the melasma lesions, that we have many changes that I mentioned previously. And then that's why we are not so surprised that there are some articles that mention about the use of focused ultrasound for the treatment of melasma, even though focused ultrasound cannot do anything with the excess pigment, but at least they do a dermal remodeling. So there are some studies that mention about the use of focused ultrasound for the dermal transducer, like 1.5 millimeters, that then you can make the melasma better. And you can see from this picture, even though the pigment is not go away immediately, you have to wait, but at least you see some degree of improvement because you create a friendly and nicer dermal environment. That's why you have to think of doing something with the dermal component as well. And that's where you don't get the melasma recurrence. So to summary of my talk, I think I try to walk you through many single steps that can make melasma worsen. So we have to take care of each part, and then our melasma patient will get better, and also they don't get the recurrence at the end of the treatment. Thank you for your attention.
Thank you, Professor Pachramon. Next speaker is Dr. King Song Lim from Malaysia. He will talk about invisible innovation about rejuvenation. Please.
Hi, Ting Song. Okay, yeah, okay. While waiting for his slides, I would like to inform everybody this is a highlight session. This is a new session that IMCAS Asia never had before. So I like to make it a highlight for every year. So you want to come back and hear what we do in Asia. As Professor Vasanov, actually he has done a lot of study. He has so many study that can answer you based on evidence based. So you can surely that you treat the patient effectively and safely with all the his informations.
Right.
Now one of them are here. Each of them, not one of them. Each of them are here. They are like number one of their country. So I picked one of the best of each country to speak what will be their secret.
Yes,
Okay.
thank you, Dr. Achima. And then Dr. Achima texted me and said, what secret sauce do you have? Please come up with one. So I do have one. These are my conflict of interest statement. I think the whole process of thinking about tissues into layers was based on cadaver. That means we do postmortem tissues, and they are all dried up tissues. And the interesting is, in the living anatomy, it doesn't always look the same. Just to show you a little bit of how our skin and the connective tissue looks like beneath them. When you cut the tissue, you can tell the skin and all the tissues beneath them are one connective tissues. They look like spider web, but in real life, they are more hydrated than this. This is a little bit more dried up. But if you go deeply into it, you realize that these connective tissues looks lubricated, they are hydrated, and they are actually spanning everywhere. And the interesting part is, in our tissues, in our body, we are not made out of just cells. Cells are residents of this continuum of fibrillar network. As you can see here, it continues to move. And whenever there's some inflammation, you can see bubbles in there. And once in a while, you can appreciate there are cells moving in between all these connective tissues. That means this structure not only built as a structure, it has many functions. First, it builds up the volume of the face and the body, not your cells. It's these connective tissues. And it also allows highway of energy to flow. At the same time, it is what that brings nutrients and energy to all our cells. And these connective tissues actually wraps around muscles, fats, and it attached to the skin. So don't look at skin as one single layer, but it's a continuum of this whole connective tissue. And look at the fat cells here. It's amazing. It's not like one big chunk. It's more cells that is attached and wrapped up by this connective tissue. We saw this video because of this plastic surgeon called Jean-Claude Guimbarteau that started videoing endoscopic videos of our living tissues. He did it since 30 years ago, and he has hundreds of videos showing that. And this changed our concept of we shouldn't look at our tissues as single layers, that's dried up tissues, but now we have to look into a continuum of tissues that actually feeds the surface. And therefore, whenever we pick up the skin, we are not picking up the skin, we are picking up every tissue beneath them. And in a microscopic way, these connective tissues translate into cytoskeleton. So it's attached into our cells and actually goes into our cytoskeleton and talk to our nucleus. So it's one single continuum of a structure that helps us to tell what to do and holds every single thing in our body. So like I say, it's not fixed and static. It's continuous moving. And the interesting part is, after it moves, it doesn't go back to the same place again. That means it's continuous finding a new balance. It's not a fixed structure. So it's a body's tent. What we see up here is the connective tissue holding together. It's not the cells. Therefore, if you place a lot of fillers into your face, you are not helping in terms of volume because you are now disrupting all these connective tissues that is building your volume. The cells are not giving you that volume. And therefore, the whole concept of aging equals to volume loss equals to tissue loss is actually a wrong concept. So when you put things in there, you only stuff a tent with a lot of stuffing, but not helping it tense up. It also brings us a question. Is the bone holding our body, or is our body holding the bones? Let's say if we leave the bones tacked up together, it goes to fall on the floor. Is the whole hydraulic system in the body that's holding every tissue in place. And that, we call it tensegrity. So forget about the layers. So what we need to do is to heal that matrix. So how to heal that matrix? There are a specific cell called fasciocytes. It's a cell that actually helps to hydrate these connective tissues and maintain them in the whole hydraulic system. And whenever there's dehydration and also scarring of these tissues, what we see is changes of tissues and fibrosis. And this fibrosis is going to lead to impingement of your nerves, your connective tissues, your lymphatic system, and your blood flow, and that actually causes your connective tissues no longer agile. They are not gliding, but now glued. And what we see is skin quality deterioration. That's why whenever we talk about trying to help our cells become younger, it's not giving them new cells. We used to think putting stem cells in there are going to help. But this is a study that shows you when you put an old cell in a young ECM, the old cells get younger. But what happens when you put a young cells in an old ECM? The ECM doesn't get younger. The young cells get older. So how to improve ECM? You have a lot of skin boosters, of course. Instead of injecting into the skin, let's go deeper. Let's go into the connective tissues. And this is what we see. We see improvement in the skin quality when you go deeper. And that have shown a lot of improvement in skin quality with time. You see reduce of redness, you see how the skin firmness, skin tone evenness, skin surface evenness actually improve with time. What else can we do? We can do things like polynucleotides. This is after one time of polynucleotides. And again, 3 months after 3 injections, you can see how they actually look younger. So what we are doing is no longer filling, but trying to enhance and make the ECM healthier. This is 6 months after 3 treatments. We can do around the eyes, as you can see here. And why do we need too much of energy or ablate them when we can restore the ECM? Exosomes is another thing that we can help restore ECM. As you can see here, skin quality improves. Just by doing 2 times, you can see really good results. And reduce of inflammation, because when you suppress and you actually control the inflammation, you help in terms of reducing fibrosis. How about scars? In the past, what we do is ablative lasers, burn them, resurface them. But what we're creating is more fibrosis. What we need to do is to feed them with nutrients, give them nutrients, give them regenerative substances, make ECM healthier again. And then your scar improves. What about collagen? Now there's a big hype in terms of coming of injectable collagen. It's very different from the old concept where collagen are used as fillers. We use it as food. Feed the connective tissues with collagen, and you start to see your patients getting younger because you see great skin quality improvements. And of course, there's a lot of energy-based devices and a lot of nutrients, a lot of substances that are regenerative, which I won't go too deep today. I'm just giving a piece of my thoughts. And I think what we need to do is rule one. Don't hurt the matrix. Don't inject boluses. Don't go and kind of cut them and burn them. Let them heal. Don't overstimulate. People jumping biostimulator, trying to use foreign body reactions or try to stimulate and create damage so you can heal. But we might actually create more scars and fibrosis. The best way to do is feed them with the nutrients, vibrate, keeping agile, move them, and let them regenerate. With that, thank you very much.
Thank you, Teng Song. Very excellent lecture to us. Next, another famous speaker, Dr. Peter Pang from Taiwan. He will talk about triple layers, triple C shape, triple device, peri-orbital rejuvenation.
Dr. Oh, who is here? All famous. All famous. Already been selected.
Thank you, my friends, as a chair. So I should say, okay, I'm going to talk a very short talk about the triple layer, triple C, and the triple device for periorbital. Yeah, we know the periorbital and perioral are very dynamic area. So this is my position in different societies. And disclosure, nothing for this talk. We know the aging process quite well. We know that related to many of the structural changes. If you take a closer look of the periorbital region, you can see the eyebrow position along the forehead, over the temporal, infraorbital area. They all have changes that related to the layer. Although we just heard a new concept from friends of Teng Song. So take a look at these changes that not related to one layer. We need to address different layers, not only from the skin, also from the subcutaneous fat sliding, and also the SMART and the muscles will play a role. So this is infraorbital. This is from my son's drawing. We published this a couple years ago. So you can see different layers, muscles, fat, superficial deep fat. So causing of the eye bag, that's a lot of different factors you can see. I highlight this in yellow. That's all related to the laxity of this periorbital region. So the concept of triple C is outer C, that related to the surrounding area, the forehead, the temporal, and the cheeks. And the middle C, that is inner of the temporal area, and even the inner C is just of the upper and the lower eyelid. We can use different device. For example, the outer one, we can use like a HIFU device, like a monopolar RF. And until the inner side, we can use like a monopolar RF and also like a parallel beam ultrasound. So the upper eyelid, so first talking about monopolar RF, that's targeting the skin and subcutaneous fat fascia. So we can elevation of the eyebrow and the eyelids to make a double eyelid. You need to see immediate tightening and lifting. That's a very important endpoint to get the better result. Other devices that can target up to deeper to the SMART layer, you also need to see immediate result. That's a best practice in my hands. So we also can improve the skin quality around the eyes by this particular device. So we also can improve the under eyes eye bag. That also includes the skin elasticity, the fat, we can use this particular device to improve this. So others like this particular device, also ultrasound, but 7 polarized beams. This device we can enhance, make the eyes bigger. We also can enhance, like you can see this laxity around the eyes. So we can use, especially under the eyebrow area, if you lifting the eyebrow with your non-dominant hands, or with your assistant, and then you can tuck it there to improve the, also can improve the skin quality over there. And this device also we use for the eye bag, because the eye bag, remember, one factor is the skin laxities. You can also improve, you can see. Also, I think that every device you need to see the endpoint, especially you are talking about lifting. And we also have other device targeting especially the muscles. This, by this publication, you can see that can lifting the eyebrow by 1 to 2 millimeters. So, but lastly, don't forget the injectables. Toxin, this publication, injection of the glabella and the crossfit, and can elevate the eyebrow and also can make the eye bigger in static and also in dynamic. So toxin do have we do a small study, a split phase. One side is more kind of a full dose, one side is a half dose, smaller dose. And we checking the elevation of the eyebrow. You can see the eyebrow position a little bit higher when that is a fuller dose over there. Up to 2.5 months is still higher. So also we can use toxin make the eye bigger. So you can see like this young patient, when she smiles, the eye becomes very small. And we do the treatment like toxin and fillers. You can see this when the patient smiling even after 3 months, it's better, have a bigger eyes. Yeah. So also the HA filler, especially for infraorbital, that's a quite nice improvement. This is a case you can see like this after we improve the appearance of the eye bag. That's a very useful tool you need to skillful. So in conclusion, I think the sagging will, not only the skin may have a fat reposition and also have smarts will be more laxities. And we need to consider these all 3 layers and this triple C concept to target. We can use different device. And lastly, don't forget the toxin and the fillers. And in combination, you can get in the better result. With that, I thank you for your attention. Thank you.
Thank you, Peter. Very excellent lecture. So I'll introduce next speaker, Dr. Dong-woo Shin from South Korea. He'll talk about micronized ADM in facial aesthetics. Micronized ADM is a really hot topic in Korea now. So I don't know if it is available in the foreign countries.
Yeah, we one brand is about to approve, the other one is already approved.
Okay.
Yeah, so we are actually waiting to try. Yeah, I will wait to
Please,
try.
Dr. Shin.
Thank you for your introduction, Dr. My name is Dong-woo Shin. I'm from Navi Plastic Surgery, Korea. And today I'm going to talk about micronized ADM and its clinical use as skin booster and volume replacement. Before I start the lecture, I have to apologize due to the next schedule. I have to leave the lecture place, so I might not be taking questions. Okay, about 18 months ago, a new concept entered the aesthetic market in Korea, the micronized ADM skin booster. At first, a lot of people doubted. But in only 1 year and a half, micronized ADM has become the leading skin booster in Korea right now. And I think in 2026, the hottest topic in Korean medical conference is not PN, it's not PLLA, PDLA, PCL, it's micronized ADM. So today I'm going to talk about the micronized ADM from volume to skin booster. So what is micronized ADM? So it's derived from human cadaver. You remove the epidermis, you get an epidermis. And after purification process, we remove the cells and sterilize it. It becomes a beautiful sheet of ADM. And this has been used in plastic surgery for a long time and other fields as well. And in order to use it for injection, we micronize it and it becomes a micronized ADM. So because it derives from the human dermis, the components of micronized ADM is essentially ECM. It's mostly composed of collagen, elastin, and GAG. It works through a dual mechanism when it comes to our body. First, it works as a biological scaffold. Next, it gives a regeneration signal. So when it is injected into our body, it acts as a scaffold. The cells start to infiltrate and migrate, and there is a neovascularization. And next, it gives the active regeneration signal. When ECM protein is broken down, it gives a signaling called metrikine. And what it does, it acts on fibroblast to induce collagenesis. So there has been different generation of skin boosters. I categorized by how it works. We have a fourth generation skin booster, which is a collagen stimulator. They are a synthetic polymer or a biostimulator. It includes PLA, PCL, calcium hydroxyapatite. They work through the foreign bioreaction, inducing the collagen. And now we have a fifth generation skin booster, which is micronized ADM. With the fourth generation skin booster, which are synthetic polymers, it has a problem of foreign bioreaction. It's really hard to get the desired collagenesis because when the host has little foreign bioreaction, there will be no clinical outcome. However, if the host shows a lot of response, then there could be a lot of side effects, such as severe inflammation, granulomas, or nodules. So now we need a safe and more predictable injectable, and that is micronized ADM. Micronized ADM also can overcome conventional HA fillers limits. Because its nature, HA filler could migrate or be deformed due to gravity or pressure. Also, it always carries the risk of vascular compromise and Tyndall effect when used in the thin skin. Micronized ADM is actually a biological scaffold that could solve these problems. So as you all know, if we use the HA filler for thin skin, we do have a Tyndall effect because of the light scatters, it gives a bluish color. Here are my clinical application of micronized ADM. It's most commonly used as a skin booster. And next, it could be used as a filler substitute for volumization. It could also be used for scars or adjuvant to surgeries. So micronized ADM provides collagen-based structural support within the dermis. That's why I believe that it's considered a true skin booster. It reinforces dermis itself, leading to improvement in tone, texture, and firmness, giving the skin the true radiance. When using it as a skin booster, you can either inject manually or use the special injector. The important thing is not to inject too superficially because it could cause nodules, and not too deep because if you inject too deep, it'll reduce the efficacy. Micronized ADM can essentially substitute where all HA filler goes. It's especially useful for area with the thin skin because it does not have Tyndall effect. I find it very useful treating the dark circles. Dark circle is caused by two main elements. One is structure, the second is pigment. Structurally, because of tear-trough deformity and septal fold bulging and skin laxity. And for pigment, because the skin is very thin in the lower eyelid area, it tends to get hyperpigmented easily, and the vessels and muscles, they are transparent. What micronized ADM does is it could actually not only replace the volume, but it could correct the tone, because micronized ADM itself has naturally white color, and also it thickens the dermis. And it's scientifically proven that in long term, it reduces the melanogenesis. Here are my clinical cases. For this patient, I used micronized ADM as a skin booster and for dark circle. So I injected micronized ADM whole face, and for lower eyelid, I injected on the tear-trough deformity using the cannula. So 1 month after the injection, as you see, the right side is 1 month after the injection. You can see her skin quality has been improved. Her skin looks more glowy. And if you take a closer look on the left side, you do have some breakouts and redness, which is a sign of inflammation, which has been improved. Actually, in the cellular level, it's been proven that the micronized ADM actually has an anti-inflammatory effect. If you look at the lower eyelid area, dark circle has been improved. On the lateral view, there is less shadowing. This patient, I used micronized ADM to treat the dark circle. The patient had a tear-trough deformity. Not too much of a septal fat bulging. If the patient has a lot of septal fat bulging, I would do the surgery. So using the cannula, I injected micronized ADM on the tear-trough area. The beautiful thing about micronized ADM is that because it does not have a Tyndall effect, it's safe to use in the superficial layer. When you use HA filler, it's quite challenging to use it in the superficial layer. So when I'm injecting micronized ADM, I inject both subcutaneous and submuscular. So I inject both deep and superficial. And after 3 months, I think her dark circle has been improved. On the lateral view as well, the shadowing under her eye has been improved. I also like to use it to augment a pretarsal roll. In order to have a useful look on your lower eyelid, it's not just about the tear-trough. I believe that you should have some volume on the pretarsal area. But conventionally, it was hard to use HA filler because of the Tyndall effect. So for this patient, I injected micronized ADM onto her pretarsal roll. And as you see, after 1 month, now she has a beautiful pretarsal roll volume, which makes her eye look more useful without Tyndall effect. So here are my take-home message. First, I believe that ADM is a very safe and predictable biomaterial. Because it's derived from ECM, it can integrate well within our tissue and provide stable clinical outcomes. It's very useful as a skin booster and volume replacement, and I believe that ECM is our future injectable. This is for my presentation. Thank you so much for your attention.
All right. Thank you so much. I also believe that it will be like, a big trend, a future trend, big future trend around the world. I have a question for you before you leave. I have a question about, do you think what would be a major barrier of using this product in healthcare system?
So I think in plastic surgery field and other surgical field, we have been using ADM for a long time for breast reconstruction or for rhinoplasty. Urologists or orthopedic surgeons, they have been using ADM sheet for a long time. So I think it's a pretty safe and effective material. I think the barrier is personally I think it's the approval by the government, because the government system are different. In some culture, using the cadaver for the aesthetic use could be resisted. So I think the only concern is the approval.
Okay, so besides the concern about the ethic, but what about infection or some sorts of that can harm the patients? How?
So I think compared to other foreign material that comes into our body, because actually when you inject ADM, the cells actually can migrate and vessels grow in. I think our body is more susceptible, less susceptible for infection, because when we use micronized ADM for face, we only use about 150 milligram, which is very little. But for like breast reconstruction or like rhinoplasty, we use like several grams. Even if we use that much amount of material, there is not much of a side effect or infection. So I believe that because the cells can migrate and actually vessels grow in, it's more resistant to an infection. Of course, it can't be 0%, but I believe that it's better than other polymers.
All right, so you believe that it's really the mechanism of action of this is the ECM remodeling, right? So
I believe it's both remodeling and being a scaffold.
Okay. All right. Anyone have a question for him
Actually, that's
or comment?
as I told you that ECM is very popular right now in Korea, and the thing is that not many doctors are using. It has been just a year, right? Dr. Shin is just so some side effects are occurring right now. If you inject to the subcutaneous layers, then there should be some vascular complications, right? I have reviewed some vascular complication of skin necrosis case, which was performed the same product like Ritual, and so it's if doctors are using more and more, then the side effect will become more and more. So we have to see that. We have to see it. But until now, it is quite effective.
All right. So we keep our finger crossed for the the next technology. All right. Thank you so much. Thank you.
Thank
so
you.
much.
Good morning, everyone.
Next. Another top doc from Asia, Jung Seo Kim from Korea. He will talk about photothermal activation of PRP using meta cells, enhancing platelet-derived growth factor release.
Yeah, good morning, everyone. Good to see you again, Achima, Dr. Oh, and Dr. Shin Dong-oh. They are very excellent doctors. and I'm a doctor. I often inject the platelet into the face and the IV infusion. Why? Why? The platelet is my friend. I'm a doctor, but the platelet are also doctor too. Teeny doctor living inside our body, and they never sleep, they never take a vacation, they travel through the entire our body, and then searching for the wound and damaged tissue. And whenever they find the problem, they immediately start treatment for free. That is why I have always had the great respect and thanks for the platelet. Today, I would like to introduce my friend. The platelet is a very busy doctor. In fact, he has at least the 9 different jobs. Let's see what he does every day. Many things, 9. The first job is, my friend is traditional hemostasis. When the blood vessel is injured, platelet going there and responds to 3 steps. First, adhesion, the wound, the exposed collagen and bone windband factors, injury site. Second, the activation, and they change the shape and extend the pseudopodia and the ATP production and increase the granule from his pocket. Third, the aggregation, activate platelet, contact each other and communication, and then they make the clot and then stop bleeding. The thrombocytopenia can develop, the petechia, and because of bleeding, even without the trauma. Even in healthy blood vessel, the platelet continues patrol and support the vascular endothelium. The third job, tissue regeneration, is a very important function in the modern PRP therapy. In each platelet have alpha granule and dense granule, the many granules, including the growth factor, PDGF, activated fibroblast, VEGF, angiogenesis, TGF-beta, EGF, FGF, IGF, HGF, so many things. The first job is, my friend is acting the fibroblast by PDGF and the TGF-beta. So as a result, fibroblast produce more collagen 1,3 and elastin and HA. And the fifth job is angiogenesis to stimulate the new capillary and for oxygen delivery and nutrient supply. And there's something we don't know. They also regulate the immune system. They express receptor such as TLR2479 is to allow recognize the bacteria, virus, and fungi. The seventh job, platelet, is stem cell activation by the SDF, PGGF. And eighth job is extracellular vesicle secretion. And ninth job, they have a mitochondria, when stimulation, ATP production, then calcium signaling increase, then alpha granule secretion increase. That is exactly where the photobiomodulation come in. A recent study using the red light 630 to the 666 nanometer and the infrared 800 nanometer suggests that directly stimulate mitochondria in the platelet. And that is the main story in my presentation. So first, take a look at the traditional active platelet. Historically, the PRP has been activated by using input chemical agent such as thrombin, calcium chloride, calcium gluconate, and ADP. The thrombin is most powerful, but too much and aggressive. So the bovine thrombin can make some immune reaction. Then the calcium chloride is probably the most common use activator. So although the chemical activation is effective, but this leads to an important question. Can we activate the platelet in more controlled, more biological way? Can we wake up our doctor's platelet with only light and temperature instead of the chemical? So why are we interested in the photothermal activation? Because of no side effect and safer when we're using the photothermal activation platelet. The ATP increased, fibropodia began to form, the sprouting the arm begin to extend, and the calcium signal and the secretion, the alpha granule, like this, the image. So I would like to introduce the Metacell technology. The MTC is to close the system devised from designed to stimulate platelet using only the light and the temperature without the chemical activator. So no additive chemicals, no contamination. It's very safe. There are many light and many temperature setting. You can use that, but we like the red light and infrared light instead of blue light. The photostimulation is not new. For decades, lower level light therapy, LLT, has been used for the wound healing, pain control, and collagen synthesis. The basic concept is LLT is light stimulation, the mitochondria in the platelet. In other words, light can wake up the platelet through this pathway. The red and infrared is the main, the sweet spot for the photomodulation. And platelet contain, there are many, the multiple granules like this image. And platelet are not simple cell, highly organized functional unit, but without the nuclei. Please remind this the many multivesicular structure and exosome within the platelet in this image. You can see that now the platelet is actively secretion using the extracellular vesicles. Unfortunately, we have not enough time today. We can discuss more about this. And on Sunday, I have another speech. Please join on Sunday. So enough theory. So let's see what happened in real patient. PRP has been reported export hepato, the protective, anti, the fibrotic, and antioxidant, so etc. The regeneration effect. So when PRP is IV, the chemical activation became impractical when the IV infusion and risky. So the left side is my own blood sample. As you can see, it's quite cloudy. It's, maybe the hypolipidemia. It was a little embarrassing and depressing to see that, my result. But on the right side, my blood appeared much clear after the MCT, photothermal activated platelet IV therapy. I tend to now wake up early and feel less tired than before. Of course, this is just my personal observation. This is my laboratory data. My ALT, the liver function, is 93 to 67. It's an amazing result. The cholesterol decreased dramatically, 380 to the 140. The HDL, good cholesterol, increased 35 to the 40. The LDL, the bad cholesterol, decreased 100 to the 30. Also, the TG decreased 780 to the 500. So importantly, there's no change in my weight. My medication is the same. I was very interested in this result. So in another article, the patient are not eligible for the other anesthetic treatment due to the several comorbidities. Before asking my patient to do some new technology, I prefer to experience by myself. So on the left side, you can see the very old man. It is me. Unfortunately, it is me. In my face, the swelling and more the wrinkles and tired. The left is before light is after the activate platelet IVN injection of face. A little bit became younger and healthy. I don't know. You can decide. They say before and after only the activate PRP IVN face injection. Also, one more thing, I create the personalized mist for every patient using their own blood. The red mist is aggressive version, and the yellow mist is a gentle version. This mist works very well because inside the airplane, air is so dry. I never board a flight without this my mist. The other patient, 90 years old man, is before and after skin little bit tightened, wrinkle improved. Also the skin the calming, the forehead wrinkle improved. Only the activate platelet injection. So in conclusion, the platelet activation is not about destroying the platelet. Traditional chemical activation force the platelet to release their content. In contrast, the photothermal stimulation may awaken the platelet in more physiological and controlled manner. Please not to force platelet to burst, but to gently may wake up that, because platelet is our friend. They work for us every day, everywhere in our body, without rest, without payment. I'm a doctor, friend of platelet. Thank you.
Thank you. I know now why you look younger this time. I almost don't recognize you. You look younger this time. Yes. Okay. All right. So our next speaker, Dr. Lee Won, another top doc from Korea. He will share his new technology on prominent ear by HA fillers ultrasound mapping.
Okay, good morning. It's not very good. Korea lost the football. 1-0. You know, Son Heung-min should have make a score. I'm so dissatisfied right now. Okay, it's previous doctor were talking about very difficult things like ethical issues of the micronized ADM or very difficult PRP like IGF, EGF or something. It's so difficult, right? But mine is very, very simple. HA filler injection. Like he was the very old idol, Korean idol, very popular, HOT. And by that time, I was thinking, oh, very prominent here. It was like 20 years ago, something like that. But right now, it's Korean actors, actress are a lot of famous people has prominent here. Because of the photograph, because of selfie, right? My daughter's always doing like selfies, right? But if you do the selfie, then its proportion is very important. So what they are doing is that making a prominent ear, right? Before we had the otoplasty for the prominent ear, reducing the prominent ears to making a lying ear. So this is Mustard otoplasty, and we all did this. I did this a lot of time, and a lot of doctors in the world were doing these operations. But right now, it's opposite. Oh my God. I was thinking about, they are making put some stickers to hold the ear prominent. It's very cheap. And in China, a lot of paper came because of the making HA fillers for the autoplasty. So this is a Chinese PRS paper, and those are the before and the after. Does it looks better? Is the proportion is better, right? And another case, another Chinese PRS paper, they show the prominent here. So the proportion is okay. It's a lot of doctors are right now doing in China and also in Korea. It's simple. There's another paper correcting line ears to make a better proportion. It's like a trend, aesthetic trend, right? Another paper. So if you think this is better looking, then try that. But if it's not, then just don't do it, okay? But it's quite popular in China and Korea right now. But as you know, we have a problem. We have complications. This is a paper of monocular vision loss after ear filler injections. Actually, injecting the ear area has external carotid artery branches, right? So relatively, internal carotid branches, such as supratrochlear, dorsal nasal, or supraorbital, is very, very dangerous, as you know. But this case is external carotid. I'm not sure about the mechanisms, but it looks like they are going to the internal maxillary artery, and then goes to some variations into the ophthalmic artery. But anyway, there is a case. Not just one case. There was another case. Two cases. One case is Giga line, and the other case is Ellavie filler. So we always have to think about complications. As I told you before about the ADM, more and more procedures are going, then more complications occurring. The same happens when we inject the skin boosters. If you inject skin boosters to the subcutaneous layers, then there are lots of arteries, and there might be some problem. It's a science, right? So we always have to think about complications. And another thing was facial paralysis. She was injected 9 cc of HA filler in one side. Wow, right? Wow. 9 cc is quite expensive, right? Oh my God. And she had a paralysis. Another case of paralysis. Another case of paralysis. And also necrosis. So, if you make that situation, what would you do? I mean, it's just very difficult for us also. It's for plastic surgeon, it is very, very difficult. So the most important thing is that not to make those kind of things, right? Yes. And when you think about ear artery, yeah, you have to think about the vessels. So there is a superior auricular artery, and of course that's posterior auricular arteries running. So if you put Doppler ultrasound to the area, that you can see the posterior arteries running. So if you look at the proof, and then you mapping it, and then you inject other place. It's very simple, right? So make a lying ear to prominent ears. But if you see the posterior artery, there is a very big posterior artery, right? So you can see that if you inject HA filler in that artery, then you can make a, paralysis, something like that. And also, superior auricular artery is very important when you detect to the very upper side of the ear. And lastly, and the most important thing is this, is central auricular cephalic regions, because those area you inject fillers for make prominent ear, right? But I had a study, and so there was a 6 case out of 31 there was an artery there. Tomorrow I will have to have a live injection program. So if you are interested for the making a Doppler ultrasound, then I will show you tomorrow. So inject and inject. Because tomorrow I have a session. I will show you tomorrow, okay? And this is the filler I'm using it. I'm using it very hard filler because you have to have a very hard resistance to hold the ear for prominent, right? So that's the G prime and the G dot prime, and G star is the hardness. So I'm using the most G star fillers, which is L'Oreal number 6. And this is before and after. And before, after. Before, after. Before, after. Before, after. So this is the paper I submitted to aesthetic plastic surgery, and I think it's quite safe method. Every doctor who want to do the HA fillers for the prominent ear, then you should use the ultrasound. Thank you very much.
Thank you so much. And thank you so much that you always try to emphasize about complications. As we also have, I'm sorry, while we're waiting, I would like to call Dr. Zhu. Yes. Professor Zhu Haizun from China. He will share his experience on facial contour rejuvenation using comprehensive strategy combining minimally invasive lifting and tightening according to a Chinese phenotype. So what I'm going to say is, thank you, yes. What I'm going to say is, we have such a great session yesterday on the pre-congress and beautifully showing cadaveric dissection together with ultrasounds. And it's beautifully shown, how risky this area, on the ear. So, thank you so much that you're trying to emphasize that, safety is priority, even though you get a good result, but, we have to also know the anatomy and everything. Yes. Please.
Yes. Thank you for the introduction, and it's my honor here to learn from the colleagues and friends. This is a great session. I have known the new concepts, new products, new tech, new equipment, and also the doctor from the Korea gave us attention to the complications. So, as a plastic surgeon, we are the surgeons how to use these methods to our patients. So today I will share our technique, daily work to minimize our classic surgical procedures, how to do the face rejuvenation in our Asia or Chinese population. I'm Hai Song Xu from Shanghai. I'm in Shanghai Nan's People's Hospital, and we are a teaching hospital. So usually we use classic methods and principles to treat our patients. While as assisted medicine, we need more minimal invasive, customized methods to give our patients more good results. So how we use our academic methods to give the patients a more comfortable results. That's our university doctors to try our effort to refine the methods. So based on the assisted medicine, we have different concepts. Even in Asia, we have a different ratio, different concepts. So based on our Chinese assisted concepts, we have published some papers based on not only the soft tissue contouring aesthetic guideline, also we have some concepts to how to refine our bone contour. So combined with the hard tissue and the soft tissue, I just conclusion our aging or our assisted medicine in face procedures to three concepts. One is for the aging phase, we usually have the problem is a facial sagging. The other problem is volume loss. And for most dermatology, the care is the skin laxity or the skin quality. So as we are surgeons or doctors, we are mainly face these three main problems, and we will find our methods to treat these patients. And based on the patient's anatomy, we have different layers, and we are a facial plastic surgeon. We divide the facial layers to 5 layers, and different layers we can use different products and different equipments and also different procedures to treat the problems. We know as the SMART is a very important anatomy landmark, so we also need to focus not only the superficial soft tissue fat compartments, but also the deep fat compartments and the bone structures. So now more and more patients, as they are early aging and they are very anxious or eager to treat their early aging problems. Like we have some papers conclusion with patients like 30 age, they are also very concerned about their nasal folder layers and the tear trough problems, and also the middle face sagging. So with the early aging, we can see mostly we are the middle face sagging, middle face problem, and the wrinkles. So we need we need to evaluate the severe of the middle face and the problems. Like these patients, we can see the middle face is sagging, but the patient's only like around 30 years. So this like face problem is not only the skin problem or the soft tissue problem, but also the facial contour, the facial bone support problem. So we need to change we can see the out facial contour, and also we need to focus on the middle face sagging and how to treat the problem together by combined methods. So for these patients, we use injections, use thread lifting, and also for the out part, we use fat grafting. So together we combine the methods. So this is a temple injection with fat graft, and we can make the facial contour more ovular and more smooth. And for the middle face, we can use not only the fat, but also the hyaluronic acids and the products to supporting the middle face. So this is the patients before and with thread lifting and injection together, and changes the outer contour. Together we can see it will more younger based on the facial contour changing, not only the soft tissue only lifting or supporting. And use the thread lifting and combined with injection, we can make a very fast recover and the minimal invasive procedures compare with one methods. And also for the young patients, more and more patients, they are carrying their jawline. So We can also use energy-based tightening, also combined with lifting, threads lifting together with a faster recovery results. These patients did zygoma reduction and the middle face staging, and we also use mini face lifting together, combined with injection and the liposuction. The superficial fat compartment, we can reduce the volume and lift the middle face. So for the patients more than 40 or 50 years old, the most problem is soft tissue sagging. And we need to focus also on the lower face sagging and evaluate the severity of the soft tissue sagging. So these patients, we do a very minimal invasive mini face lifting combined with injection, the forehead with Botox, and the middle face with mini face lifting and fat grafts. And you can see, based on the classic, the all-air incision, we use a half-air incision just around the hairline, and after 1 month later, the incision is not so severe, and the face surgery recovery period is very short. You can see after 2 days, 3 days, 1 week, we can combine with the surgical procedure with the injection, like a very minimal, like just like a thread lifting. We can have a fast recovery result. While with the very old patients with the middle face and lower face sagging together, we need to do the classic face lifting, but also we need to combine some new procedures like the fat pad. We remove the fat compartments and refilled with the middle face, and we use equipment tightening, so we can use a surgical procedure, change the face contouring. And after the facelift, we also give the mesotherapy to the skin, and the skin quality also can better result. So conclusion, for the aging face, we have the three main problems. One is facial sagging, volume loss, and the skin laxity. So the comprehensive strategy with the minimal invasive procedures, lifting, tightening, and the mini fat grafts. And also we can combine with the equipment and products together to get the whole result is the best results. And also the patient will follow you in a long period. Thank you for your attention. Thank you.
Thank you, Dr. So. Next speaker is Dr. David from Philippines. He will talk about a longitudinal management of rosacea in skin of color.
Okay, so good afternoon, colleagues. First of all, I would like to congratulate Achima on this new initiative and this new session, Asian Secret Sauce, which I feel will be a platform for expert opinion, research, and cascading of consensus guidelines. So I'll be talking about rosacea in Southeast Asians in general and skin of color. For my disclosure, I promote the advocacy on the proper diagnosis and treatment of rosacea, especially in skin of color, because it has been a neglected skin condition among Asians. I'm a member of the REACH Global Scientific Committee on Rosacea, which is Galderma Initiative, and we currently published consensus recommendations on the longitudinal management. So in 10 minutes, I'll be discussing this agenda. First is to identify some knowledge gaps on rosacea in skin of color, shares some modest gains and minor breakthroughs in research that we have conducted, although we don't have enough time to discuss them in detail. What are the medical implications of rosacea in Asians and in skin of color? And more importantly, what are the aesthetic concerns? What are the practical tips and future directions on rosacea research and management? So why Asian secret sauce? Well, because we have our fiery Asian flavors, especially from the Malaysian and the Indonesian sambal and Thailand food, which I am a big fan of. And we record the highest temperatures in the ASEAN region with like high heat and humidity, and definitely it is affecting our rosacea patients. But the problem is, it was traditionally considered as a condition primarily affecting our white colleagues or fair-skinned Caucasians. However, now we recognize, because of those who promote the advocacy, that rosacea is not uncommon anymore in the Asian population, except in East Asia, like in China, Taiwan. It is a well-recognized condition. The problem exists in the Southeast Asian countries where brown skin is the predominant skin color. So it has always been a conundrum in skin of color when I started research on rosacea, because definitely your brown skin or your melanin masks the red color. So it is difficult to detect erythema in darker skin phototypes. Most often, rosacea is misdiagnosed, undertreated, suboptimally treated, and the main problem is that there are overlapping features of rosacea and acne in younger patients, and most of our patients are treated as just cases of acne without the rosacea component. And how active, we have been very active in promoting the recognition of rosacea. But the numbers in local registries, especially in the Philippines, is still very low, so this is indeed a challenge for us. And we see these patients every day, and we always question whether we are making a diagnosis of acne and rosacea, or acne or rosacea. They react to anti-acne medications like tretinoin, benzoyl peroxide, and we see these cases with facial puffiness, so this is rosacea. They come to the clinic being diagnosed by other dermatologists or other physicians as other skin conditions, but this is rosacea, and we see a lot of them every day. And in a research that we have just recently completed, so out of 436 respondents in a study on clinical manifestations, we asked them, are you aware that you have rosacea? So most of them are Filipinos with brown skin or type 4, skin phototype 4, and the answer is no. So it constitutes 96.4% of all these rosacea patients. And we have tried to identify these knowledge gaps. So basically, there's limited Southeast Asian, also South Asian with our Indian colleagues, and Filipino data on rosacea. There's underrepresentation of skin of color populations, because we always believe that rosacea is a disease of Caucasian patients. There is a need for population-specific diagnostic approaches, because our genetics are definitely a little different. And then we should address challenges in what is called phenotype-based diagnosis, which is what we recommend when you make a diagnosis of rosacea. So this has been recently completed research in the Philippines on knowledge, attitudes, practices of dermatologists as well as general physicians, because we are entering an era of universal health care already, and they should be detected as soon as possible. And then we came out with clinical characteristics of rosacea among patients, Filipino patients, so less than 500 patients. And interestingly, these are the highlights of the rosacea research that we have completed. So the current practices of Philippine dermatologists demonstrated lower alignment with contemporary guideline-based rosacea management. There is also local medication inavailability, because if you remember, most of the rosacea products were taken out of the market, especially in Southeast Asia. So we need urgent, structured guideline dissemination. And this is a role of the longitudinal management of rosacea, which we have recently published. These are consensus recommendations of approximately 9 dermatologists from all over the world with expertise on rosacea, and I'm assigned on rosacea in skin of color. So we call this the REACH project, which is Rosacea Expert Advice on Combined and Holistic Approaches. It identified the need for something that is streamlined to address suboptimal intake of recently existing guidelines from the National Rosacea Society and the ROSCO panel. We tried to develop to fill a void in rosacea management because we all differ in management of rosacea in skin of color, and we focus on clinical presentation, diagnosis, phenotype, which is very important, triggers, what is the foundational skincare which is being recommended, and combination strategies, long-term therapies. And this is the REACH longitudinal pathway framework. We don't have the time to go in detail. You can download the actual article, but just a brief introduction to the longitudinal rosacea pathway framework. So there are points A, and this is during the time that you see the patient, and they tell us their stories about rosacea, being misdiagnosed as acne in the past. And they enter the medical pathway, they answer quality of life questionnaires, and then they progress to point B, in which a correct diagnosis is very crucial. So after point B, we go to a treatment which is agreed upon by the doctor and the patient, and point D is actually the maintenance. So this is the lower part of the longitudinal framework. So there's point A, point B, going to point C, going to point D. And as we go from point to point, we may either step down or step up with our management. But our goal is always patient satisfaction and shared decisions on treatment, whether we are giving systemic or oral medications, topical therapy, lasers, and the most crucial is when we try to perform procedures in these patients, especially when they are in their inflammatory state. So what are the medical implications? We'll go over photos fast because we don't have the luxury of time, so please take note of the new classification because this is totally different from the old one. This is the 2018 ROSCO criteria. And when you diagnose rosacea, you just need one diagnostic feature, which is persistent centrofacial erythema or PHIMA, which is growth or enlargement of connective tissues. These are triggering factors in the Philippines, I think in Asia also, so definitely heat, skincare products, humidity, and our fiery Asian foods. And this is an example of what we call a phenotype. So in this patient, there is persistent centrofacial erythema, inflammatory papules and pustules. We get baseline photos. We try to explain the complex pathogenesis of the disease. It takes time during the first consult. And then we give them systemic treatment, topical treatment. We control the inflammation first before moving forward to controlling just the erythema. And later on, we can recommend some vascular lasers like the 577 nanometer laser and the pulse dye laser. And these are just some examples in skin of color where redness is rarely detected at first. So this is persistent centrofacial erythema, inflammatory papules and pustules, long-term follow-up with younger patients. You don't have to place them on long-term isotretinoin as if they will adhere with a foundational skincare for rosacea. So this is after 5 years. Very much controlled erythema. We try to limit their exposure to the sun, outdoor activities. And for difficult cases, we observe that if you see a patient with rosacea and you don't know what to do with the patients, topical ivermectin is just an excellent option. This is a patient in which systemic medication was not given but was prescribed photoprotection and foundational rosacea skincare. For aesthetic concerns, which is very interesting, we try to recognize early and late phymatous changes. I often get surprised when we present patients injected with like high volume of fillers when in fact they have rosacea and very obvious facial puffiness. We try to manage inflammation. We try to identify highly inflammatory patients because they are actually high risk. They react to procedures. They develop allergies to hyaluronic acid, and we should be able to treat PIE, PAH. These are the forms of phimosis rosacea, and you see them every day, and we offer them procedural treatments to make them beautiful. But the problem is connective tissue hypertrophy. So this is metaphyma, rhinophyma, natophyma, rhinophyma, sebaceous hyperplasia in younger patients. This is rosacea in the Filipino family. So when you get to see a younger patient, we ask for the photos of the parents, whether they have phimosis rosacea. This is untreated rhinophyma at age 50, and we definitely, from the beginning, we try to prescribe like Botox to correct the glabellar abnormality, when in fact that's connective tissue hypertrophy. This inflammatory rhinophyma in teenagers. We have to be very careful with doing procedures on these patients like chemical peels, lasers, etc., because they are highly inflammatory. And these are cases of phimosis rosacea. We may not see them in general because they belong to the low-income social bracket, but some of them are suffering from, for example, in this patient, an ocular type of rosacea which has existed for like 40 years already. There's improvement of rhinophyma with some systemic medications like low-dose oral isotretinoin. Some patients are referred to me by plastic surgeons before they conduct rhinoplasty to decrease the sebaceous hyperplasia with both oral medication, lasers, etc. Your patients who keep on coming back for revision surgeries, cosmetic surgeries, rhinoplasties, and if you see them, they have phimosis rosacea, facial edema. And we find them a little irritating, but they actually need help and explanation. So disappointed with Botox, fillers, energy-based devices, 48-year-old female, but with an anti-inflammatory diet, rosacea, foundational skincare, and oral medications, she has improved dramatically. They react to lasers, ablative ones, with post-inflammatory erythema, post-inflammatory hyperpigmentation. They develop immediate frosting and erythema noted after medium-depth chemical peels. And I recommend that we start aesthetic procedures once redness and inflammation are already controlled. The first consult is always crucial. This is how to treat rosacea successfully. So they have to undergo a bespoke or a tailored approach. In Skin of Color, these are recommendations.
It's over time.
This is my last slide. Thank you. And combination treatment is always recommended. And for maintenance therapy, it has to be evidence-based. Environmental modification, anti-inflammatory diet, decreasing inflammation, and future directions in the future, maybe AI apps and tools will be available. So thank you very much again, Achima, for the opportunity. Yeah.
Thank you
Thank
so
you.
much.
So our last speaker is so anxious because it's overtime, right? So please welcome our last speaker, Dr. Mukta Sajadev. She's a dermatologist from India. So her topic is NS-based device for melanin-rich skin. Please.
Good afternoon, everybody. I know you're all hungry, so I'm not going to keep you too long. Lasers in Skin of Color 2026. It's a very broad topic. Just one of the disclosures is I'm a KOL for Alma Lasers. Okay, what are the challenges in melanin-rich skin? The challenges then, the challenges now. We have complications. What do you need to remember? Pigmentation is an indicator of aging. Lasers and other procedures have complications, and we have challenges. So what is your new concept when you're using devices? Melanin-sparing rejuvenation. Treat the dermis, minimize epidermal injury. The discussion has moved beyond laser safety. We're talking about precision laser delivery, biologically intelligent treatment design. the biggest innovation is not a new wavelength, it is smarter delivery of energy with less PIH risk. Why do we need a new approach? Because we have the increased risk of PIH. Why do people burn? They burn because you're using too high energy. You're over-treating, poor skin prep, poor technique, and we have an inherent tendency of pigmentation. This is still happening, okay? So what do I need you to do? I need you to choose your wavelengths. I need you to control the injury, reduce the inflammation, protect the epidermis. You will have faster recovery. The evolution of laser technology has gone from ablative, fractional non-ablative, fractional pico, hybrid, regenerative. What is the direction of innovation? Less heat, more precision, less downtime, reduced risk. So fractional, what does it do? It keeps good tissue. It keeps healthy tissue. Your healing is better. Now, what you need to know when you're treating laser, Fitzpatrick is not enough for you. These are the classifications, non-Fitzpatrick. These are the classifications. These are the classifications, and these are the classifications of skin of color. We have more than 25 classifications. This is the latest. This is 2025. We are looking for practical strategies for Fitzpatrick's 4 to 6. 1064 nanometers first, fractional deliveries, low fluence approaches, multiple sessions rather than aggressive treatments, avoid aggressive thermal endpoints, prioritize inflammation control. This is pretty much one of my most used devices in the office, the Q-Switch Nd:YAG. I've been using devices for 30 years now. I've been using the technologies. When we are using a Q-Switch technology, you get high energy pulses, short nanosecond pulses. It targets the chromophores of the pigmented lesions, and you get a photoacoustic effect. With this particular technology, the ClearLift Pro, it's one of the devices I use where I can actually target the depth of where I am going. So I am an intelligent laser user. I'm making my choice. I know where I'm going. I'm protecting the surrounding skin. I'm reducing my PIH risk. So when you look at the histopathology, you can see that the technology decides where you are going to go. For photoaging, it'll give you selections of which handpiece you should use, how deep you should go. Now, what I would like to show you when you're doing, for example, a tattoo removal, yes, this is what you're supposed to get. Look at the befores and afters. Very good in lighter skin. The gas bubbles are the laser heating the ink or the melanin pigment. The gas rises to the surface, and then you will get that frosting that you see. In darker skins, it can blister, even with the lowest energy. So you can have PIH risks. You need to be careful. Clinical results for OTA. You can see the frosting. It can go either way. So your post-care is very, very key on what you should do. But a nice before and after. Again, freckles. We have people coming in for freckles. I always say I can't get rid of your freckles. I can improve them. They are going to come back. But you can get nice results. You get the erythema, you get the little bit of crusting, and you get an improvement. Is it going to come back? Yes, it is. But is it safe and effective in darker skin? Of course. The fractional pico, the workhorse for darker skins, for melasma, acne scars, rejuvenation. The evidence in Asian skins, there is a significant improvement in texture, dyschromia, a very high safety profile. What are your strategies to reduce PIH? The selection, the technique, and here I'm going to tell you that your post-treatment care is extremely important. Barrier repair, sun protection, anti-inflammatory creams, pigment suppression when needed. Other devices on the market, the hybrid technologies, the combinations of Nd:YAG, erbium-YAG, 1470, 2940, carbon dioxide with a 1570, 1540, 10,600. Why are we looking at hybrids? Because we have found that one technology is not enough for everything. There is no one device that does everything. Intelligent laser usage. I will say this again and again. Understand your wavelength, see where you're going to target, and choose the wavelength correctly. A little bit on what's new. The hair removal lasers have gone from stationary to motion. Another device I like, I would have never 20 years ago told you can use an Alex in darker skin. Now we use Alex, diode, Nd:YAG all in one because you can target different areas of the hair follicle and then you get a better result. What else is new? Eflornithine masks are new. Eflornithine adjunctive treatments to your laser technology. Robotic laser hair removal, already in Dubai. Clinics are running on robots. The robots are doing the lasers. Okay, this is what's new. This is where we're headed. The non-ablative and fractional. You have selectional, fractional photothermolysis. We also have something which is a very new technology called CCT, Controlled Chaos Technology. And this is very nice. It's a non-ablative device, and I can target where I'm going even with a non-ablative device. I can get to 3 different depths with a single pulse. What else is new? Laser coring is new. 2910, laser coring removes slight, tiny little columns of tissue, which stimulates new collagen and elastin. The 1927 thulium is new. Very, very popular, the non-ablative fractional for darker skins, because here I'm not seeing any complications. Medical indications for devices. We have what we call assisted drug delivery. You're all using fractional, you're all creating microchannels, you can all put something on the skin to enhance the penetration. Whether you're treating acne, you can use retinoids. Whether you're treating melasma, you can use melanosome inhibitors. So use your devices sensibly and smartly. What's the next chapter in lasers? The next chapter is post-procedure adjuvant care and neurocosmetics, home use lasers, AI, lasers and diagnostics, the hybrids I've told you, LAD, laser-assisted drug delivery, and the future depends on inclusive research. You've got all the home use devices, use them to your advantage. They are adjunctive treatments to what you do. You have integrated skincare. You have products showing evidence of better healing post-laser, published data. You have neurocosmetics. It will bring down the pain. It will reduce the inflammation. It will enhance patient compliance. And you have AI-assisted treatment optimization. You have imaging systems. Get an imaging system in your office. What is the change? The change is you avoid fully ablative lasers in skin of color. Avoid high-energy pigment chasing. Avoid a single device treatment philosophy. Avoid treating Fitzpatrick as a skin of color scale. It doesn't work. Thermal injury is not your endpoint. What do? You use hybrid platforms, you use fractional Q-switch, fractional PICOs, you use regenerative dermatology, objective assessments, personalized protocols, precision dermatology. The last 2 slides just going to tell you the regenerative laser dermatology. It's lasers with exosomes, PRP, regenerative topicals, growth factors, definitely showing potential benefits for healing, reduced inflammation, and improved collagen synthesis, lower risks of PIH. So the future, precision, fractionation, combination therapy, an objective skin of color classification, regenerative medicine, and control inflammation. The future of lasers in melanin-rich skin is not higher power. It is fractionation, combination, and inflammation control. So your success in darker skin is measured not by how aggressively we treat, but how intelligently we preserve. Thank you very much.
Thank you, Dr. Sachdeva. Very well organized lecture. Unfortunately, we don't have time to Q&A because we are so delayed. So, Dr. Achima, would you mention about a closing remark?
Yes. So next year, we're going to have more time for discussion. I promise. I promise, okay? I'm sorry for today, yes. Yeah, well, we're going to do better every year, okay? Yes, thank you, everybody, to stay until the end of the session. But anyway, you will see all of our speakers, walking around, so please stop them and asking questions. That's how we learn, challenge them.